This is a private special urological clinic which is only dealing with minimally invasive surgery, mainly with endourology and also with robotic assisted surgery. And today it is our task to present you two famous endourological procedures, namely one mini PCNL and one flexible uroscopy. And we selected two patients which make us possible to discuss all the different topics dealing with these two surgical procedures.
Sven, just 1 second. You know, before we the connection, I presented you that one of the pioneers in mini PCNL, and we are so happy to be together today.
Yes, I always say that mini PCNL is not equal to mini PCNL. It's the same as one car is not the same as another car. And from my point of view, it is really advisable to learn the very small details. These are details that are not mentioned in the scientific literature, but sometimes these details are really necessary to get a good treatment result.
Perfect.
Before we start our live surgery in Pforzheim, I would like to introduce my staff members, and I would like to begin with Ute. Ute is the head of nursing care of operating theaters, and she was also present in some foreign European countries to help me with live surgery. And we have some other guys. This is Dr. Menchi, coming from Syria. He's also very experienced in endourologic surgery. And Dominic is also a nurse from the operating theater. He's very familiar with all the techniques we are using to transmit live surgery. And then we have two guests coming from the Richard Wolf company. They are going to explain some more details of the whole new laser later on. And you know that urologist is unable to work without anesthesiology. Therefore, I would like to show you Dr. Allemann. Please, Dr. Allemann, come a little nearer. Dr. Allemann is a very experienced anesthesiologist dealing mainly with urological patients. Okay. Now the next step would be to introduce the case, and therefore I asked Dominic to show the details of the patient we are now treating by mini PCNL. Please show the next slide, please. This is a 58-year-old male patient. He's a recurrent calcium oxalate stone former, and he's suffering from Crohn's disease. He has a so-called secondary hyperoxaluria, which had been treated, but unfortunately he had developed a large renal calcium stone. And during the last week, this stone, which has a diameter of approximately 13 millimeters, moved to the proximal ureter and is obstructing the urinary flow. We have so-called infundibulum stone. Now, next slide, please. This is the KUB and IVP. On the left-hand side, you see the stone, which is a radiopaque stone. And on the right side, you can see that there is a certain dilation of the renal calyster system. The stone is located in the infundibulum, but we can clearly see that there is not 100% obstruction. Therefore, up to now, we did not invert any double J stent or something like that. And now my first question to the audience is, what is your suggestion? What are the treatment options we have?
Sven, just 1 second. I have a question to you because all audience are very interested. You know, you presented an IVP. So in Germany, you still use IVP, I mean, as first and important investigation?
No. Let me comment on this. What I'm now telling you is only my personal opinion. Of course, the CT scan, the native CT scan, is the imaging modality of choice today. No question. We also have a CT scan from this patient, no doubt. But from my point of view, in the age of an endourological approach to stone disease, we need the morphology of the urinary tract. And the very old, well-known IVP has really a good value for an endourologist, because what do I really need? I need a good indication to decide about the treatment, and I need something like a road mapping to reach the stone. All other details are discussed or decided by means of an endoscopic approach. I don't need anything. I only need the endoscope to see the stone, to disintegrate the stone. Therefore, from my point of view, IVP is also suitable today. And by the way, the radiation exposure in IVP is less than in contrast enhanced CT scan. But this is only a small comment from my personal point of view. You are completely right. CT scan nowadays is an imaging modality of choice.
Sven, I am completely agreeing with you. In all my discussions with my assistants, I said, I still like IVP, but they said, no, professor, EuroCT is the best. And, what do you think about this?
I know this opinion, of course. I'm just having a look to my senior fellow, and he has a similar opinion, and I understand this. But an IVP is an easy-to-perform X-ray examination. It can be done by the urologist, and it is something like a summary of all the different planes in one image. If you have a urography by CT, you always have to look a lot of images. Of course, this is possible, but I think it's not almost necessary in every case. Once more, to say really, to bring the message on the point, CT scan is the imaging modality of choice, but there is a certain increased value of the so-called old IVP because we are treating endoscopically.
Sven, do you have the CT images at all?
Once more, please.
Do you have the CT images on the screen?
Yes, we have CT scan from this patient, but it is not prepared.
Okay, sure.
Because it is only a native CT scan. It had been done outside, and it showed the 13 millimeter stone in the renal pelvis without displaying the morphology of the ureter. Therefore, from my point of view, IVP image is more suitable to explain the case.
Did you say 30, 30 or 13? Because on the KUB
13,
or the...
13, 1, 3.
Okay, sure. Just because it looks much smaller on the simple X-ray.
Yes, you're right, but it is 1, 3, 13 millimeters.
Sure.
I think we start the procedure, if you agree.
Yeah.
Okay. The patient is put in this position, well known, and the first step is to perform a rigid cystoscopy.
So while he's doing this cystoscopy, who would do PCNL in this case, mini PCNL?
Okay, once more, please.
Who will do ureteroscopy?
I'm very sorry, but probably the microphone is not well connected to the Zoom conference. Please, could you repeat the question once more?
If there is a question, has to be the microphone.
Yes.
I would like to ask the technicians to turn the microphone louder. We are really unable to understand the participant.
So we were asking between ourselves earlier. That's why probably you did not hear us. We asked who will do PCNL on this case and who will do ureteroscopy. And
I'm doing both procedures, no problem.
Sure, sure. But in terms of a choice for this one, for this case, which would you go for in a typical patient like this? Would
so
you?
The first step is always to perform a retrograde pylography. Now we are doing the cystoscopy, emptying the bladder, and changing the optics to a 30-degree optic. And this is also combined with the Albaran instrument. This means we have a 70-degree angle, viewing angle on the uterine orifice.
So in terms of position, do you put them in just standard lithotomy?
Just a moment, we are going to show you the endoscopic picture. Just a moment. Okay, can you see the endoscope?
Yes.
Yeah. Okay, this is the left-sided orifice, and now we are using a uterine catheter. We prefer to use something like this with a T-man tip. Can you recognize this? This is easier to invert the uterine orifice. Okay?
Yeah. So do you do
Whenever there are questions from the auditorium, we can answer and discuss them. No problem.
Yeah, it's a question. Why you started PCNL using this position? I mean,
Yes,
yeah.
I like to perform. Now we have inverted. I answer later on. Now we inverted the ureteral orifice, and now we are switching to the X-ray. Please show X-ray.
We are just seeing the external views. We are not seeing the endoscopic or, here we go, probably.
Okay, now we are applying a little contrast dye from retrograde, pushing the uterine catheter forward. Okay. It is really an infundibulum stone. Now we can magnify the renal area. And what you can also see is that we are not using a C-arm. We have a special X-ray table, which is specially designed for endourology. Now we have a magnification of the proximal ureter. Okay. Now you can probably see that in the inner pelvis, the large stone is now lying. You can see two other places in the lower calyx where some smaller stones are located. And now we push the uterine catheter up to the renal pelvis like this. And this is the position where we are going to fix the catheter. Now we can have a look outside, please. Okay. The cystoscope is disconnected. The bladder is emptied. And the cystoscope shaft is taken out. And now, the uterine catheter is pulled like this, some gel. And then the catheter is inserted under the uterine catheter, like this. You can hold it with two fingers over there. This avoids any movement of the catheter. Now you can push forward the transurethral catheter. The catheter is blocked in the bladder. Okay. hold the uterine catheter, and now we fix the uterine catheter to the transurethral catheter, and the retrograde procedure is finished. So, first one around the catheter, the uterus catheter, then around the transurethral catheter. That's all. The nurse is connecting the uterine catheter. Now insert an overview, please. Okay, now the uterine catheter is in place, and this facilitates the percutaneous puncture later on. Are there any questions so far?
Just a variation on the technique. If you wait until you've got the right position, you've got the patient in position for the PCNL before you put any contrast in. And of course, with ultrasound, you don't need to put contrast in.
Are there any questions so far?
Yes, Ben, question from the floor regarding the positioning. Do you need contrast if you are doing the access with ultrasound? And do you need the lithotomy position to get the access?
Okay, I'm showing you the puncture later on, but I can tell you at the moment that we do not need contrast dye to perform ultrasound-guided puncture. But what we are doing is we are puncturing under ultrasound guidance, and we are dilating the tract by means of fluoroscopy. Therefore, it is better for us to have a uterine catheter and be able to apply some contrast dye. This is the first point. The second point is that the uterine catheter allows us to have certain dilation of the renal calyceal system, and this facilitates the ultrasound-guided puncture. And the third point is that we are using a mixture of contrast dye and methylene blue, which means we have a colored contrast dye. And after successful puncture of the calyceal system, we can control our puncture by means of a clear blue urine coming out of the calyceal system. But we are going to show this later on.
Great, thank you. I think there are different ways of, as probably you could imagine, some people do it with that, some people do it flexible cystoscope, supine, just to save time. But yeah, I think, as you said, I mean, everybody has their own way and no wrong or right answer. Any more questions from the floor? No? So are you going to change position now?
There are different possibilities to reach the aim. It is very important from my point of view that you are familiar with your own technique. And it is not advisable to have 5 or 6 different techniques in the same urological department. Therefore, from my point of view, it should be one well-trained procedure which should be accepted by all doctors and staff members. Okay, if there are no further questions, we are leaving the operating theater now. The staff members are turning the patient into prone position, and I just take off my sterile clothing, and I take you, and we are going to the operating theater just next to this operating theater, and we can discuss the details of mini PCNL. You can come with me. We are going to the other operating theater, and I can show you the details of mini PCNL in advance. This makes us easier to make the procedure later on. Please come with me. Okay, this is all sterile, therefore I take on my sterile hand gloves And now I can explain it to you what is happening later on after the patient had been put into prone position. Could you see the table? Could you see the table?
Yes, we can.
Okay. Our aim is to make mini PCNL. Our aim is to make mini PCNL easy. And easy means that we should limit the number of instruments. To be honest, you only need 3 parts of the instrument, or 4. This is a puncture needle, then a special guide wire, can be a cheap one, the dilator, the amplat sheath, and the nephroscope. That's all. If I'm invited to do life surgery in other countries, I only take these 3 things in my luggage, not more. Okay, this is the puncture needle. It is suitable to have a puncture needle with a special tip, which is very sharp and should be clearly seen. Be careful, it's sterile. Which should be seen by ultrasound. Therefore, you should try different manufacturers and find out which is the best needle for your ultrasound set. Needle. The puncture is done.
What size needle do you use?
Once more, please.
What size needle is this?
This is a 1.3 millimeter needle. This is good visible together with our ultrasound system. I show it later on. After the puncture, the inner part of the needle is taken out and the guide wire is inserted.
And is that PTFE super stiff or standard? Or
yes, this is what I want to show you. This is really a very cheap stainless steel guide wire. This is not hydrophilic. It is very cheap. It is really the most simple guide wire ever. Okay, you push it forward, and after that, the puncture needle is taken out. Okay. The guide wire remains in place, and this special stainless steel dilator, which is reusable, is inserted over the guide wire under fluoroscopic control. You cannot do this under ultrasound guidance because this solid material is not so well seen under ultrasound control. Once more, over the guide wire into the renal pelvis. After that, we are using a stainless steel amplat sheath that is also reusable, very cheap. You can operate on with this sheath for years, I think for decades, because it is really very, very strong material. This amplat sheath exactly fits to the dilator. Now the amplat sheath is pushed forward and placed in the renal calyceal system. After that, the dilator is taken out. Once more, this is only a one-step dilation. We do not need any alkane dilators in mini PCNL. They are really not useful. And we don't use any plastic dilators because the thickness of the wall of the amplat sheath is very thin in stainless steel and not so thin in plastic material. After the dilator has been taken out, you are using the mini nephroscope. The mini nephroscope is smaller than the amplat sheath, and if you have a look at the tip, you see that there is a certain space between the nephroscope and the inner part of the amplat sheath. And this space is needed to migrate all the small stone fragments in mini PCNL while you are disintegrating the stone. Once more, the irrigation is coming through the nephroscope, and then the irrigation flow goes to the space between nephroscope and inner part of the amplat sheath and running out of the amplat sheath, and the fragments are coming through this space out of the patient automatically. This is very important to have an open system. You see there is space between nephroscope and amplat sheath. This is really very, very important.
What's the size of the sheath and the scope? What French?
This nephroscope has an outer diameter of 12 French, and the amplat sheath has an inner diameter of 15 French and outer diameter of 18 French.
So you have 3 French between,
yes.
Only 3 French.
This amplat sheath is coming from the company with this special device. And I know that some of the urological colleagues are using this rubber to close the amplat sheath. This means that the nephroscope is not free. This is not an open system. And my strong advice is never to use this. Never use this blue device, because you always need a low pressure system with a free outflow in the space between amplat sheath and nephroscope, where the irrigation water comes out automatically. If you are using the mini nephroscope like this, the pressure inside the calyceal system is very low, and you are not afraid of developing any pyelonephritis or something like that. The only situation where you are using this blue device is if you are performing a flexible endoscopy. You are inserting a flexible URS, for example, then you need this rubber, this blue rubber, because you need a certain dilation of the renal calyceal system. But always perform mini PCNL once more with an open system, like this. Okay, if you have finished, you insert the guide wire to the amplat sheath once more, remove the amplat sheath, and then we prefer to insert a nephrostomy tube. This is a 12 French nephrostomy tube. Of course, you can perform a tubeless or totally tubeless PCNL, but from my point of view, this small nephrostomy tube does not cause any pain in the patient. Therefore, sometimes it's better to use this nephrostomy tube. This tube also allows you to have a second look because it is easy to use a tract later on. Okay?
So Sven, just a remark. You know, you said that we have 3 French. I mean the space between nephroscope and the inner part of access seat. Is correct? 3
yes.
French. 3
yes.
French is 1 millimeter. 1 millimeter, that means 1,000 microns. So this is the limit of your stones that could be removed. Is correct?
Yes, you are completely right, but you should know that we are always dusting the stone. The stone fragments are really smaller than 1 millimeter. Sometimes, or normally, we do not see these very small fragments. I can show you later on during mini PCNL. We are not looking at the size of fragments. If we are seeing fragments, the fragments are too large. This is also a good advantage of mini PCNL, because the outwashing of small fragments is an ongoing and continuous procedure, which is happening during the application of the laser. But if you are asking me what is the maximum size to remove stones, you are completely right. If I want to remove larger stones, I have to remove the nephroscope, like this, and then the larger stones are coming automatically through the amplat sheath. And the maximum size is approximately 4 to 5 millimeters.
Yeah, it's correct. So for the audience, if you try to dust, it's necessary to dust less than 1 millimeter. I mean less than 1,000 microns. So you need a laser with very good possibility to dust. I mean, maybe it's thulium, maybe it's TFL. Because with holmium, we have all experience, 1 millimeter is possible, but between these lasers, at least in our hands, thulium is the best. I mean for dusting, I mean for stones less than 1,000 microns. Are you agree with me?
Yes, I completely agree with you. We need the dusting. Mini PCNL is really very, very important because this is a main point in doing mini PCNL and the main difference to conventional PCNL. Let me show you this grasper, for example. This is a grasper. This grasper is suitable to be used by means of the mini nephroscope. But in mini PCNL, we don't use this grasper. We don't need this. This is only to remove a double J stent through the renal pelvis or something like that. But in conventional PCNL, this is really necessary to put out all the fragments. In mini PCNL, we don't need any grasper, any forceps, nothing like that, although it is available. As we do not need this grasper, I put it away. Normally, we don't use this. Okay. What we can do now is we can have a further discussion with the laser, application of laser, the technique of laser, and so on. And I'm not sure if there are no further questions from the floor or from your side. We can switch to the laser and probably we can discuss all the things associated with the application of the laser.
Great, yeah, thank you. Any questions from here? Yeah, there is a question here. If you come to the microphone, please, or...
Okay.
Please.
Thank you very much. Very nice work. I wonder, do you have an adequate and precise measure for intrarenal pressure in this? Is there any correct measure of intrarenal pressure during using this mini PERC? And you said that there is a 3 French. Is it adequate to prevent post-operative pyelonephritis? And what is the incidence of post-operative fever and or pyelonephritis in your patients?
Okay, I can answer you exactly because the probability of developing fever after mini PCNL is exactly 6.7%. Once more, look at the detail. Nephroscope, amplat sheath. And you see there is really a good space. The space is large enough to allow the water to come from the kidney through the amplat sheath outside the patient. And this leads to a low pressure condition inside the renal pelvis. If you are interested, I can tell you some more comments on this question. Is there time enough, Petrizor?
Yeah,
okay. Let's switch to the next table. Just I'll show you this.
Sven, but you have to admit
different set of amplat sheet. Once more, the main amplat sheet we are using is this. This is the mini PCNL, the original amplat sheet. But we also have a set of different amplat sheets available. And these amplat sheets, they are completely different. Big size, this is 16 French, 14 French, this is 10 French, and 8 French. What we can do now is we can select an appropriate amplat sheath which is appropriate to the patient. For example, if we are treating a large stone, we are using the large size of amplat sheath. If the stone skin distance is long, we are using a large one, the longer version. If we are treating a patient with a very small skin to stone distance, we are using a short one. The shorter the amplat sheath is, the better the so-called vacuum cleaner effect is. Or if we are treating a child, we can use this. This is small diameter, small size. But of course, it is very difficult to wash out the stone fragments. This is the next step of mini PCNL. You have different sizes, different diameters, and different lengths. And to each diameter, there is a special dilator available, like this. Yes, for example, small amplat sheath, small dilator. This maybe this one. Okay, this one. Or large amplat sheath, you take this one. Okay, but this makes it more difficult. Our scientific data shows that the best combination of length and diameter is this kind of amplat sheath. This is 15 French inside, and this is 12 centimeters long. This is really a good combination, and from my point of view, you do not really need all these different types of amplat sheath. We are using this one.
Sven, I have a comment. You know, you show us access it between 20 and 8
Yes.
French, but 8 French is not mini PCLL.
Yes.
8
This
French
set-
it's another story.
Yes, you are completely right, because this set of amplat sheath is not a typical mini PCNL. We call it perfect perk. Perfect perk means we do not use a 12 French mini nephroscope, but a smaller one. This is only 4.5 French.
Yeah.
And if you are using a 4.5 French mini nephroscope, you can use such small sheath. This is like UMP.
Yeah.
The question was, what is the diameter? What about the stone fragments? And I wanted to show you that the question cannot be answered easily. You always should decide according to the particular situation of the patient. But if you are not so involved in mini PCNL, therefore it's easier only to have this size. This is suitable in almost all cases.
Yeah, it's
Only for scientific interested urologists. This one is enough.
I completely agree with you, but we have to be very clear. With mini PCNL, with maybe 20, 18 French, you can treat the stone and you can remove the stones. But with 8 French, you can only treat. I mean, you can only obtain dust. Is correct?
Yes, you are right. In these small amplat sheath, you really only have dusting.
Yeah.
And it takes a long time. But if you have a small stone, for example, 10 millimeters, I think Olivier Traxé would treat this by flexibuloscopy, but you can also treat this by mini PCNL using this very small sheath. You are completely right. Everything is right.
Okay, probably is better. Is the patient ready to start the surgery?
Yes,
Just
the
so
patient is almost
just to make
ready,
sure
but
the
next
timing.
step would be to have a short discussion about the volume laser. And I'm going to give the word to Mr. Asker. He's waiting. And please come with me. And I can introduce you, Mr. Asker. And he's explaining you all the important details about volume laser. Please, Mr. Asker.
Yeah, also from my side, firstly, welcome to Goldstadt Clinic, welcome in Gottsheim, in South Germany. My name is Hermann Asker. I'm working as marketing manager in the urology department at Richard Hall. And I will give you today a short overview about our laser device, which we are using during the both live surgeries today with Professor Lahme. So the device is a 70 watt Volvium pulse laser device with a maximum power of 70 watt. The maximum frequency is 60 Hertz, and the maximum energy which is possible is 5 Joule. So you can use with this device laser fibers from 200 micrometers up to 1000 micrometers. In our product portfolio, we have reusable and disposable laser fibers. So for the lithotripsy, of course, the recommendation is a high power laser fiber with 200 micrometers or 272 micrometers. And for the soft tissue, for the BPH treatment, for example, for enucleation, we recommend a laser fiber with a diameter of 550 micrometers. So that's all. That's the short overview. I would like to say check the GUI of the laser, and then you can have a better overview over the laser. So we will switch on now. Just a second. Okay. Switching on now. The benefit of this laser device is that you can use it for lithotripsy and for soft tissue at the same time. The system is very, very easy. The handling is very easy also. So let us check the interface now. Takes a second more.
So what's the maximum power for the laser?
It's 70 watt, the maximum power.
30.
No, 70.
70, sorry.
70. We have also the 30 watt in our product portfolio, but this is only for lithotripsy. This device with 70 watt is for both for lithotripsy and for soft tissue. So after starting, we'll ask you which operation you will do today. So as you can see here, we have the lithotripsy mode, we have the soft tissue mode, and we have the expert mode. Behind lithotripsy and soft tissue, there are so-called presets. So let us check, for example, here lithotripsy. You can choose two settings, two pedal settings. For example, you can choose dusting, lung pulse mode, and the power fragmentation. And after that, you will confirm it with OK. And here we are with the presets. And on the pedal, on the left side, the orange one for the old one, and the blue one for the other one. So at the end, you can use two pedals for two different settings. And with the black one, black button, you can stand by the laser or put it on ready status. So of course, if the preset is not enough for the operation, you can put the frequency higher, the energy, sorry. Okay, because the fiber is not connecting now, you cannot choose the energy and the frequency. So at the end, you can go to soft tissue, the same procedure here. We have different cutting modes with force cut, standard cut, precise cut, and coagulation. Also, same here, like lithotripsy, you can choose two different settings for your foot switch. For example, force cut and standard cut. Then you just push OK. And here we are ready for the OR mode. Here you can see the emitted energy, the pulses, and you can also change the beam intensity of the pilot laser brightness from 30% to 40, 50, or you can reduce it. And also here, if the profile, if the presets are not enough and you change the presets, you can save your profiles for your own procedure, for example, here for OLED or for URS or lung. Of course, we know that the laser is not a high power laser, neither a less power laser, so it's in the middle of the range, but to be honest, it's enough for lithotripsy, it is enough for soft tissues, and as many people know, you don't need maybe the high power laser 150 watts, because we have very great experience with this laser device. We have 100 surgeries every day all over the world, and the results are more or less perfect. So, yeah.
So
if you have some questions, just ask me.
Yes, I have a question to you.
Yes.
You know, we all know that the most important thing is the energy.
Yes.
You know, when you use these kind of tools, at least in our hands, we choose 0.204 joules. And for frequency, yes, for frequency we choose between maybe 40 to 80 hertz. So we demonstrated, and also Olivier demonstrated that you know, in pilot system the power not be exceed to 25 watts. I mean, 20 watts, 30 watts, it's enough, because after that could be dangerous. So you have to combine this, you know, joules with frequency.
Of course, yes.
So I have some, you know, problems when I try to introduce, you know, this high power, because you have to have a balance between frequency and joules. I mean, between hertz and joules, not exceed 30 watts. This is very important, the message. And this is in the pilot system. But in the ureter, it's another story. In the ureter, the power, I mean the power, it's, I don't know, 12, 20 maximum watts. If you agree with me.
Yeah, of course. We saw it on the TFL technology, for example, that 15 watts, it's totally enough, or 20 watts is totally enough for the procedure.
Exactly.
So you don't need high power laser like 150 watts.
Exactly.
Yes, totally agree. Okay, I just got the message that we can go on with the mini PCNL. I think we can go on with the...
Yes. We are back in the operating theater and now performing the mini PCNL. And I would like to show you the positioning of the patient. Is it possible to show an overview of operating table? Go backwards, please. This is the patient. He is lying in prone position, and we are using a special inflatable cushion which is put under the abdomen of the patient. This is a special rubber, and this can be inflated by air pressure. This is a big advantage because the inflatable cushion can be adjusted to the particular shape of the body. Little inflation, mid inflation, or strong inflation. Now please come back. This is a field where we are going to do the puncture. And I already told you that we are facilitating the puncture by insertion of the urethral catheter. The urethral catheter is coming out at this position. This is the laser fiber, and this is the position where a syringe is connected to the urethral catheter. And inside this syringe, there is a mixture of contrast dye and methylene blue. Methylene blue is very cheap, and if we have punctured successfully, the urine is blue-colored urine coming out of the puncture needle. Now we can have a look at the X-ray picture. The We're just waiting for the X-ray. Please show the X-ray. Okay, this is now the X-ray situation. And what you can see is that the tip of the uterine catheter is under the uteropelvic junction. And now the first step is to apply contrast dye to the uterine catheter. This is to have a good visibility of the venous calyceal system. And now you can see that the stone is lying in the lower calyx. The stone has been pushed by means of the uterine catheter and is now falling in the lower calyx. Now, please have a look at the camera. Switch to the camera, please.
Yes, yes.
Please, the camera. Okay. This is to explain it to you. This is not used in daily routine, but there's spine. This is the lower rib margin. And this is the area where the puncture can be done. And now I'm going to explain step by step how we are performing the ultrasound guided puncture and the fluoroscopic controlled dilation. The first step is to take the needle. This is the needle, and this needle is put with the tip of the needle on the target area under fluoroscopic control. Now switch to the X-ray, please. This is now the X-ray. Our needle is coming. There's our stone, and this is our target area. Now show the camera outside. This is now the needle. There's the tip. Now we exactly know that the stone is located in this direction. We cannot do the puncture like this because we are unable to determine the depth of our puncture. We should use an angle like this. And in order to determine the depth of our puncture, we are using ultrasound. Now please give me the ultrasound probe. This is a special ultrasound probe where the puncture needle is coming through the probe. More detail, please. This is a special percutaneous probe. It is really recommendable. It's from Hitachi. I'm using this for 20-25 years now. Really good. And now we are putting, overview please, this ultrasound probe just exact on the line of our needle, because we know that this angle of puncture is the best angle. Some gel, please. Now the probe is put in this position, and the needle is removed because we do not need this at the moment. Now we can switch to ultrasound. This is now the ultrasound image of the patient, and the green line is the puncture line. Probably we can show the stone more clearly. This is the lower calyx, of course. There's the stone. Okay, now you can see the stone located on the green puncture line. This is the best position to do the puncture. And on ultrasound, you can clearly see that there is no interposition of the bowel. Therefore, we always recommend an ultrasound-guided puncture. It is like an online CT scan because we see everything of the anatomical structures. Now show the camera outside, please. This is the position. You remember that the angle of the position was evaluated by fluoroscopy. Now this is the best position. The puncture needle is inverted. We are using a 30-degree angle. And now we can switch to the ultrasound. And we are now approaching the lower palaeal system. You can see the needle is approaching. Now we are at the capsula of the kidney. Now we are approaching the lower calyx, hopefully. Now camera outside. Now we are disconnecting the ultrasound probes. So. And now we are switching to X-ray. Okay, now we can have a look. Yes, we are just next to the lower calyx. We are removing the inner part of the needle, and probably there is coming some urine outside, I'm not sure. Needle once more. We are correcting our position of the needle. Small syringe, please. We need a little bit more contrast dye. We are only a few millimeters away from our target area.
So you use X-ray finally. You started with you started with you know, with sonography. It's good. We are impressed, but finally you use X-ray. Is correct?
Yes, you are right. Because I'm not successful up to now. We are doing it once more. We are using X-ray once more.
I guess as there is still no extravasation, still probably we have not gone through the collecting system.
No, puncturing is no problem. Try once more.
Now for the audience.
Yes. This is the difference between live surgery and semi-live surgery.
Yeah.
So it doesn't matter.
Yeah, you know, it's a huge sentence in the percutaneous approach. I mean, the punction is the most important moment for PCNL, and you clearly demonstrated this. The success of PCNL depends 90% of good punction.
Yes.
I mean, of course.
The puncture itself is not the problem.
Yeah.
The dilation is the most dangerous part. Okay, now you can show the camera detail. This is now blue-colored urine. a mixture of blue and red. You can see how we are successful.
Yes.
This is blue. This is the reason why I recommend blue. It's much easier. Now we can insert the guide wire. This is the stainless steel guide wire. Very simple, with a pigtail tip. And now we can switch to X-ray. And the tip of the guide wire is positioned in the upper calyx. Can you see this?
So you aim to upper calyx rather than to the ureter, to the pelvis?
No, no, this is not possible because I prefer to puncture the lower calyx. And if you puncture the lower calyx, the angle between the ureter and the lower calyx is very sharp. Sometimes it is possible, sometimes it is impossible. What we here see is the normal case. Okay, now we need a scalpel. We make a small incision.
I have to say, I think most of our cases when we dilate, we aim to get the guide wire into the ureter, even if we have to change to Terumo or soft tip catheter, guide wire.
This is what we do not recommend because a stiff guide wire like this is better for dilation. Hydrophilic guide wire is easier to place in the upper, mid or lower calyx or ureter, but it is not suitable to perform a dilation. Therefore, this guide wire is better for dilation. Now we exactly know that the tip of the guide wire is located in the upper calyx over there, and we can remove the puncture needle. This is also a good help. You can push your hand like this, and if it is blue, you are in a correct position. Okay? Guide wire is blue. This is a stainless steel dilator, and it is now very important to have a straight line. This is important for the nurse. The nurse is holding the guide wire exactly in the best position. You take something like this, hold it here, and now you can turn the dilator around and push it forward under fluoroscopic control. X-ray. This is also an important point. Now the guide wire is in place. The dilator is at the calyceal neck of the lower pole, and the most difficult and most dangerous part of the dilation process is if you hit the medial wall of the renal pelvis. This is now approximately 2 centimeters away from the tip of my dilator. Now we are approaching. Don't push the dilator more than this position. Okay? Now the next step is to invert the amplat sheath. This is a very cheap amplat sheath. It exactly fits to the dilator. And the best way to manage the amplat sheath is to hold it like this. Once more, like this, with your digital finger like this. Because if you hold it like this, and there is a certain advancement of the amplat sheath like this, it is a kind of security measure. Do you understand this? Now you hold guide wire, dilator together with this, and your left arm to your body like this. Like this, the left arm, this is to fix it. And now you can invert the amplat sheath like this. Now switch to X-ray, please. Always be aware that the tip of your dilator is not pushed forward. Okay. Now have a look outside, please. Camera outside, please. can see that the blue urine is coming out here. This is clear urine only with blue color. This is a good sign. We are completely correct. If you are not sure, you can use the blue color from here, give a little color, and probably the blue urine is coming out. Now we are removing this dilator, and the guide wire stays in place for a few moments. The next step is to insert the nephroscope. This is to be sure that the guide wire and the pamphlet sheath is in the correct place. After we had confirmed the correct place, the guide wire is taken out. Okay, we are inverting the mini nephroscope. Switching to the endoscopic view, please. Now we are expecting some blue color, the system, something like that. Okay. Oh, there's a stone. Probably we pushed the stone away from the lower calyx. Now, if you have a clear view in mini PCNL, my advice is always to take out the security guide wire. I know that there may be a lot of participants telling me that this is not advisable, but mini PCNL, we need a good space between nephroscope and ablation. Show the camera outside, please. Focus on this. This is absolutely clear urine coming automatically out of the calyceal system, and this means low pressure inside the renal kidney. Can you see this?
You can see the irrigation, but we can't see the endoscopic view yet.
Now we can switch to the endoscopic view, please.
There must be more, I guess.
Clear view.
Perfect.
And the next, once more, it is very important not to have a guide wire from this moment. Okay, now we are inserting the guide wire, the laser. This is a 500 micrometer laser fiber, and the initial setting of the laser is always 5 Hertz and 800 millijoules.
So do you think that's the only stone, or probably your scope went beyond the larger one?
I'm sorry, but I was unable to hear your comment. Please, could you repeat it once more?
Do you think this is the only stone, or were there any stones alongside your track or your sheath?
I'm not sure, but it doesn't matter because we are checking all parts of the calyceal system, and we are starting with this stone, okay? From this step of the operation, we do not need fluoroscopy. Fluoroscopy is only needed during the dilation process. In the end of the operation, of course, before placement of the nephrostomy tube, we are using fluoroscopy once more.
Anyway,
always remember, we are showing this case in order to show the details of the procedure. It's not our main task to treat a large stone. This is not so suitable in life surgery because it is boring and long-lasting. This is more interesting for you because it does not last for 1 hour or 1.5 hours. Now once more, we are inserting the 500 micrometer laser fiber. The setting is 5 Hertz and 800 millijoules. This is a very soft setting, and this is only to try how hard stone is.
Anyway, is when you know, I need to make a little joke. You know, for me, this stone is perfect for flexible ureteroscopy. If it is only this, of course.
Yes, you are completely right. You can also treat this by flexible ureteroscopy, no question and no doubt. But the good endourologist is able to perform both procedures. Therefore, we are not afraid of puncturing the kidney. We all know that there are some specialists around us that are really excellent, flexible surgeons, but they are not performing a percutaneous approach. For us, it doesn't matter. And to be honest, our cutoff of deciding to do a mini PCNL is 10 millimeter size of the stone. Okay, now the laser has started, and our initial setting is 5 hertz and 800 millijoules. And we can have a look what the stone is doing. This looks like a calcium oxalate monohydrate stone. Very hard stone. I think we can enhance the energy to 1.2 joule. And this is better, and now we can enhance the frequency to 12 hertz.
So you're using 500 laser fiber rather than 270?
Oh, this is a 500 micrometer laser fiber. And now we have 12 hertz and 1.2 joule. I think this is better. And now I can show you what is happening with the very small, tiny stone fragments. They look like snow. You can see this. And you see the snow next to the stone. And these very small fragments are coming automatically to the tip of the amplet sheet. Now we can show you the camera from outside. You can see there are the small fragments coming out automatically. Now back to the endoscopic view, please. You see the very, very small, tiny fragments. And these fragments are coming automatically to the tip of the amplet sheath. And this is why we don't need any forceps or graspers. Once more, this is only a demonstration of the technique. I know that the stone size is not so large, but it's a suitable patient to show the technique. We can also do a fragmentation of the stone, but if we have fragments, sometimes it takes more time to collect all the fragments. But the interesting thing in mini PCNL is that the main flow of the irrigation is coming to the tip of the amplet sheath. And this is the main difference to conventional PCNL. In conventional PCNL, stones are sometimes migrating to the upper calyx, to the mid calyx. We don't have this in mini PCNL. Therefore, I'm not afraid that this stone is migrating to any other part of the calyceal system. It's only a question of time when all the stone fragments have come to the amplet sheath.
Any questions from the audience? Feel free to ask any questions. So what, do you use long pulse or short pulse, or does it matter?
Just a moment, I have to look. Pulse length is, I cannot see this from this view, it's a medium pulse. Medium pulses. But we can ask this to the guy from the Richard Bolt company. Maybe he can give us some more details about long pulse, short pulse, and medium pulse. Please, Mr. Asker.
So I think that this case is very demonstrative, and you know, in my opinion, after maybe 3, 4, 5 minutes, I can extract the stone with graspers. Not a problem. The size, it's okay. So you don't need to transform all this stone in dust. So I think that after, I don't know, maybe 2 or 3 minutes, Sven could remove this stone one piece, no problem. What do you think, Sven?
You are asking whether in conventional PCNL you can remove the stone in one piece.
Exactly.
Yes. Of course, I think 2 pieces or probably 3 pieces, but not more than that. But believe me, there is no indication to do this anymore, because it's better to spend a little more time like we do this, and we have a smaller puncture channel to the kidney, a less bleeding complication rate, and no transfusions. I do not remember that we had a patient with mini PCNL receiving a transfusion. We don't see this anymore. From times, we provided some blood for the PCNL patients in advance, but today we don't do this. Why? Because it's not happening. Have a look at the water coming from the kidney. Show the camera, please. This detail, please. This is the same water as the water from the irrigation flow. Blood, there is no blood, nothing. This is due to the small access to the kidney.
So in terms of the guide wire, just for another way, in terms of some people, as you said, do not like to remove the safety wire, but one option is to have first guide wire, put dual lumen, put a second wire, so you keep one outside the access sheath and one inside. Once you are in, you take the inside and leave the outside access sheath, so at least you have safety wire alongside your sheath if any problems.
Of course, you are right in principle, but if you are doing your work with patients, if you spend time, if you do not hurry, what may happen? Nothing happens. Once more, show the camera from outside. I have to explain something. Why should this migrate? What problems may occur if I have a very good handling of the laparoscope and this? I don't need anything. If someone is coming and removing this, yes, you're right, then you need a really guide wire, the second one. But the mini PCNL, in good mini PCNL, you don't need this. It's like driving a car. If you are driving a car, you always have one hand at the steering wheel, and you don't need a second one. Do you agree? Now let's look at the removal of larger stone fragments. This is now a stone fragment which is inside the armlet sheath. And the first thing I want to say is that the stone came automatically to the armlet sheath. I did not collect the stone fragment, it came automatically. Now show the camera from outside, and I show you what I'm doing. I'm removing the laparoscope slowly, and now the stone is following, and hopefully it is coming out of the channel now. There. Oh, sorry. Yeah.
Yeah. Excellent, nice. That's the Ventura technique, I guess.
Okay, this is if you have larger fragments. Okay, now we go in and remove the remaining stone. Okay, now we collect the next stone, and the stone is coming to the sheath automatically.
So you do all your PCNLs in the prone position?
Once more, now we have another fragment inside the armlet sheath. It came automatically to the armlet sheath. Now show the camera outside once more. And I'm removing the laparoscope slowly, and the stone is out. Stone is here.
Yes, nice.
Okay? And this is quicker than using a forceps. Now we are removing the last part of the stone. And you can clearly see that the stone is coming automatically. You don't have to look for the stone. At a certain point of the disintegration, the stones are coming automatically. Now the stone is inside the empty cheese. I'm removing the microstone. Just a moment. The stone is coming out. We have to try once more. It's awesome. Okay. Okay, next stone is coming automatically. It's warm. Now it's out. This is really fast. Once more, the procedure is only for demonstration. But if you have a large stone, it works really very, very good. Now the large stone has been removed, and we have a look now at the calyceal system. This is upper calyx. Always bend the instrument very slowly because there's a certain risk of bleeding. This is a way to the ureter. If you are not sure if you are correct, you can apply some glue from the ureter catheter, but I think we don't have to do so because this is a little pelvic junction. And now we have a look at the lower calyx. And in order to have a good view on the lower calyx, I'm going to remove the antler sheaths slowly. Please show the camera outside. Always turn the antler sheath around, just the right side. Always turn around like this. And now for endoscopic view, please. I turn it around, go backwards, and probably there are some small stone fragments remaining. This is the next calyx. Probably the stone, not sure. Coming back to the lower pole, going backwards, backwards, more backwards. Now we are just at the end of the calyx. I don't think that there is a lot of calyx remaining. Okay, no stone. This is the calyceal neck of the lower calyx. But now, sometimes it is better to invert the guide wire once more in order not to lose the connection to the calyceal system. You cannot, but you are not obliged to do so. Always turn around. Okay. Does the audience agree that there are no stones remaining? Now we invert the guide wire in order to have a secure guide wire while we are inspecting the last part of the lower calyx. So, took our security guide wire now. Now we can go backwards. Have a look. Oh, now there's a very small quantification.
Just down there.
Yeah.
Okay, no laser, please.
So that's what I thought in terms of when.
This is really at the end of the lower calyx.
Yeah, you can see the.
This is what we expected, but it doesn't matter. We are removing the stone as well. probably we can push it a little forward.
Yeah. So that's what I thought. I think it's very important, this step to do in terms of to look at the when you are coming out or alongside your sheath to make sure no stones left behind, because once you are dilating and going into the collecting system, especially if the stone is in the same calyx you are entering into, you might have some stones alongside the sheath, and unless you do what Sven did, you might miss them.
Now you can clearly see what is happening if you have a guide wire and the limited inner diameter of the amped sheath. The guide wire is really a security point, but now the guide wire is not that helpful for me because the stone is sticking next to the guide wire. Therefore, my suggestion is to remove the guide wire once more. And then to remove the stone. This is the reason why I don't need guide wires. And this is the stone got from the lower calyx. Yeah.
And this is a very important message, you know,
Yeah.
to control the trajectory. I mean, after you treat the stone, you must see what happened in the calyx, because exactly that your case demonstrated, it's possible to have also stones in other parts of the calyx, you know. So it's a very demonstrative case in which you are obliged to verify the entire trajectory. I mean, the pyric system entire and you know, the calyx. It's good.
Now we have to look at the outer camera. Excuse me. The next step is to clean the skin, because sometimes there are some stone fragments remaining, and if we are checking the result by means of X-ray, we should be sure that there are no stones on the skin. Okay? And now we switch to the X-ray and check by X-ray if there are any stones remaining.
Okay, question from the floor.
Yes.
Sven, I'm Thanos. Hello from Athens again.
Yes?
I'd like to congratulate you for the state-of-the-art and quite straightforward case. I know it's not so easy when you're doing live surgery. And to thank you for the continued support to ESD, because you've done a lot of live sessions in the past. I will give the podium to Professor Musa from Beirut.
Yeah, hello, Sven. I'm
Yes.
Dr. Musa from the Lebanese University, Beirut, Lebanon. I have two questions. The first question, I'm doing adult percutaneous surgery. And when I need to move from adult to pediatric, what is the learning curve? How many cases shall we do to move? The first question. The second question, how I see that.
Excuse me, one question after the other. It's easier for you and for me.
Okay.
Okay, the first question is, what about the learning curve, particularly in doing this procedure in children? Okay. The problem of PCNL is that the distance between maximum disaster and maximum success is very short. This is the main problem. Therefore, you really need a lot of experience. I cannot tell you exactly how many cases are recommended prior you have really enough experience. But probably after 20 to 50 cases, you really understood how to do the puncture. And after another 50 to 100 cases, you can say that you are really experienced, and if there is no particular difficulty, you will manage the case.
Okay,
the main recommendation I would like to give is that you always should be patient. No sudden movements of your hands, yeah? Nothing like this or something like that. Only very slow, no force, very patient, and then nothing happens. You have time enough. No one is forcing you to finish the surgical procedure in a short time. Because if you have a complication, the operative time would be 3, 4, 5 hours longer. Therefore, my recommendation is to start with easy cases, non-preoperative patients, non-obese patients, and always be slow, patient, and so on.
Okay, thank you. The second question is the amplat sheet is metallic for the pediatric. We are used with the adult amplat sheet is plastic, the Nephromax. Is there some balloon dilators for the pediatrics also, so small balloon dilators?
No, the smallest child I have ever treated was 6 kilograms.
Okay.
It was an early born small infant with 1 centimeter pelvic stone, and this was treated by the same instrument, a 6 kilogram small child, which is really very, very small. It's like this. That's the whole patient. This stainless steel amplat sheet is also very suitable to treat children. The question is whether you would like to use the balloon dilation. My recommendation is very simple and clear. Don't do this, because it is easier to have a single-step dilation with the special single-step dilator. The bleeding is less if you are using plastic amplat sheet and plastic balloon dilators. The bleeding complications are higher. You can read this in the literature. Once more, the dilator and the amplat sheet, the second one. You can use this amplat sheet and this dilator also in very, very small children. And you put in the dilator, no bleeding, because there is a compression of the tissue. And after that, you push the amplat sheath, also no bleeding. You remove the dilator, and that's all. And you can do this in Stacon stones from different parts of the kidney in multiple calyces. This is really a very safe way.
Yeah, okay. This is important, like Professor Javalet has said, the important is the punction. It should be the right punction, then the dilator is easy then. The last comment, we are using continuous irrigation with blue dimethylene and contrast medium over the ureter catheter, and you are pushing with the syringe. Is there any difference? I feel friendly if you will put it continuous irrigation with the contrast medium and the blue dimethylene. What do you think?
It's easy to comment. There's absolutely no need to irrigate via the ureteral catheter, because the ureteral catheter has a diameter of 5 French outside. This is very, very, very small. Our irrigation is connected to the nephroscope. Richtig drauf. It's connected to the nephroscope. And there's a really better flow. And give me the amplat sheet, please. Amplats. Okay, and once more. The irrigation flow is coming out of the tip of the nephroscope. And the way of irrigation is like this, coming here and going back to the amplat sheet. Why do you use such a small ureteral catheter? We are using gravity for irrigation. Please show this. This is gravity. And you can see there is a certain lift mounted at the ceiling, and we can adjust the height of the water bottles, and this is always a very stable pressure. This is very cheap and reliable. You don't need any pump, and the combination of gravity and an open system in mini PCNL is really a good combination.
So, thank you. Very informative.
Thank you very much, Sven. So,
we are just inserting the nephrostomy tube because then we can finish the surgery and probably we can discuss later. Are you, do you agree?
Yeah, yes. Only one question. In the end of the day, you will put a nephrostomy tube or not?
Yes. Normally we put a nephrostomy tube in because it does not cause any discomfort. It is not like a double J stent, and if we do a tubeless mini PCNL, it is recommended to do a totally tubeless PCNL without any double J stent. And I think it's better to have a nephrostomy tube for 1 or 2 days. What we are doing now is we are taking our nephroscope, having a last look inside the calyceal system,
So for the audience, it's very important your message.
Yeah.
So
Now,
in your cases, in all cases, you finish your operation with nephrostomy tube? I mean,
in almost all cases, yes, we are using nephrostomy tube.
but you have a
Outside therapies,
yeah,
outside
you have some cases in which you don't use this nephrostomy tube?
yes, yes, we have. Just a moment. Now
Good.
we are inserting the same stainless steel guide wire through the nephroscope under endoscopic view inside the calyceal system. Please show in any video.
Probably nothing needed.
Now show it straight. Now the guide wire is inside the calyceal system. Okay. Was habe ich da aus? We apply some contrast light. We are removing the nephrostope. Now show the camera outside. From the beginning of our operation until now, there is absolutely no bleeding. I'm sure that you can see this. Absolutely no bleeding, nothing like that. Now, if we are removing the untouched leaf, there is a certain period of time with a little bleeding because the compression of the untouched leaf is now over. Now we are removing the untouched leaf and we are inserting the nephrostomy tube.
So, Sven, again, can I challenge you here again? What's the purpose of this nephrostomy? It's straightforward operation, small stone, no active bleeding. Would it not be better for tubeless completely, patient going home either same day or the following day? Is it related to billing in terms of being a private institution? You get, not you, but in terms of the institute will prefer to stay overnight, so more billing, just for clarification.
Just a moment, please. Now show the camera outside. This side. Yeah. Now you can see, this is contrast dye. This is water to inflate the balloon. That's it. You understand this? I'm pressing contrast dye with my abdomen. And this is for dilating the balloon. Now we can switch to X-ray, please. You can see the balloon. Can you see the balloon? I can give some more contrast. You can see better. Yes, it is lying in the renal pelvis.
Sven, but
Yes.
I'm sure that you agree with me. This case is a perfect case for no putting a nephrostomy tube. So
Yes.
no bleeding, little stone, and everything was perfect. In the end of the day, zero stone in the system. Why? Why you use this? You know, we like that you demonstrated, but in this special and very good patient, in my mind, I never ever put a nephrostomy tube. What do you think?
Yes, I completely agree with you, but we are not performing the procedure as we do it every day. We are doing this more slowly, and this is a video for educational reasons.
Good.
I'm sure that there are sitting a lot of participants doing mini PCNL not every day, or probably thinking about starting with mini T-SNL, they should know what is the best way for a short learning curve with less complications. And therefore, it's always better to insert the FU3 too.